Good afternoon, everybody. Thanks for joining us this afternoon for our topic, which is ovarian reserve and fertility. When we look at patients, the first question that comes to mind with almost any couple presenting to ourselves is, do I make good eggs? Can I get pregnant quickly? Can I not get pregnant quickly? How do I know if I'm going to have trouble or not have trouble? So obviously, patients first come to us after they're trying to get pregnant mostly. Sometimes patients come to us interested in just understanding their fertility potential and are they going to have more trouble than not getting pregnant. So when we look at ovarian reserve, we're really assessing the capability of the ovary to produce good quality eggs that can result in fertilization and normal embryos. And there are a couple basic ways of trying to assess the answer to these questions. The first question we always ask somebody is, how old are they? And age plays the predominant factor in ovarian aging and the ability of the ovary to produce good quality eggs. If you look over a woman's time span, the most eggs a woman ever has is actually before you're born. When you're a fetus at about 20 weeks inside of your mother, you have 1 million eggs in the ovary. By the time you're born and start to menstruate at age 11, 12, 13, you're really down to 100,000 eggs. So when patients start ovulating or start having menstrual cycles, the ovaries together have about 100,000 eggs in them. Now, even though that's a lot less than you originally, were born with, this is a lot of eggs, because if you think of this from a practical side, most women will start ovulating in their teens and will stop ovulating in their mid-40s. So you ovulate for 30 years, and there's only 12 months in a year, so you only really need 400 or 500 eggs, but yet you start out with 100,000. And if you look at the number of eggs that are in the ovary over time, in somebody who is young, under the age of 35, you have about 100,000 eggs. By the time you get to, age 35, it's probably half of that. It's about 50,000. And by the time you get to age 40, you're probably down to about 10,000 eggs or so. Now, still 10,000 is a lot, but the eggs are older, so they don't tend to work as well. The major difference between an ovary and a testicle in a man is that the male has stem cells in the testicle that constantly produce new sperm. So when sperm are ejaculated, they're only 72 days old, which is the length of time it takes for the sperm to progress through the tubular system and mature. On the female side, you're born with whatever number of eggs you have, and you're constantly depleting them. The ovary has X number of eggs, and the eggs in the ovary undergo a process called atresia, which is when the eggs just sort of shrivel up and go away. And most of the eggs do that. You only usually ovulate one egg in a month. And every cycle that you're potentially going to ovulate, there's a catchment of a group of eggs called follicles that are potentially available to ovulate. But you usually only ovulate one, and that's why most of the time in humans, you just have a singleton birth, and occasionally can ovulate more than one, and you can get a paternal twin that comes from two different eggs, rather than an identical twin, which would come from a single egg. So the number of eggs you have get less as you get older. The other thing that happens as you get older is when you have a normal egg and a normal sperm and they get together and an embryo is formed, the incidence of what's called aneuploidy, which is an abnormal embryo genetically, meaning it has too many chromosomes. Instead of having 46 chromosomes, where 23 came from mom and 23 from dad, when the embryo starts dividing, it gets mixed up and it'll have 47 or 48, or it's missing part of a chromosome. And the incidence of aneuploidy goes up as you get older. So the first question is, how do we know if you have good ovarian reserve or not? We ask you how old you are. Somebody who's 25 in general is better than somebody that's a lot older. And as you get older, in general, you have less and less good quality eggs, eggs that are more difficult to fertilize, eggs that when they form embryos are more likely to be genetically not acceptable, and as a result of that, have more difficulty getting pregnant, or in some cases, higher incidences of miscarriage, particularly early miscarriages. The incidence of Down syndrome also goes up as you get older for the same reason, but even at age 40, the incidence of a Down's baby is only 1 in 100 per live birth. The other ways we can look at ovarian reserve are a little more scientific, other than asking you your birth date, is to look at some biologic markers. And these fall, the first set fall into blood tests called AMH, or anti-Müllerian hormone value. And the AMH level is a blood test that can be measured at any time during the cycle. There's a little bit of variation throughout the cycle, but usually it's within 10 or 15%. And there can be variation between different laboratories, because this, unlike a lot of blood tests where it doesn't matter if you do the blood test locally or you do it in Hong Kong or India, you're going to get the same result basically. AMH titers and AMH results are not as standardized as most blood tests, so it's sometimes difficult to compare apples to apples when they come from different labs. The thing that tends to be comparable is the trends. You're not going to get a super high value in one lab and a super low value in the other, but the actual number may change. And with AMH testing, that will go down as you get older because there are less granulosa cells in the ovary, which are the cells that surround the egg and mature the egg and allow that egg to develop. So the less eggs you have, the less granulosa cells you have, the less AMH you have produced as you get older. A good AMH value in a reproductive age patient would be anywhere from, it's a minimum of 1, preferably in the 1.5 to 2 range, to 4 on the upper end. And if we're looking at women that are under 35, 1.5 to 4 is a good range. If we were looking for egg donors in our program, we don't even consider women that have AMH that's under 2 because we're worried that they'll produce less eggs. Now, some women have very high AMH levels, and that you often see in women with polycystic ovarian syndrome because they have so many little tiny follicles and little eggs in the ovary that are trying to get out but just don't, that their AMH level is elevated. An elevated one isn't a problem with getting eggs to produce and develop, but it's more of a sign of, if it's valued particularly over 5, is that they're going to be very sensitive to fertility drugs, and a lot of times you see that in women who just don't ovulate normal. The third approach is to measure some hormones on the second and third day of the cycle called FSH and estradiol. And follicle stimulating hormone is what stimulates the ovary to produce eggs. And prior to the availability of AMH testing, we basically used FSH on the second or third day as our major means of assessing ovarian reserve. Tests that are very rarely used nowadays are Inhibin B, as well as what's called the clomiphene challenge test, which will look at FSH on day 3 and then after Clomid use on day 10 and seeing the rise in it. But the key elements biologically now for blood testing are AMH, which can be done at any time of the cycle, and then cycle day 2 or 3, FSH and estradiol. And you need to do the two together for it to have value. The AMH tends to be a little more sensitive in that we often will see a decrease in AMH, which is a poor sign, versus an increase in FSH associated with a normal estrogen level, which again is associated with a poorly functioning ovary or one with diminished ovarian reserve. The last marker is one that's done by ultrasound, and this is measuring antral follicle counts. In the ovary, if you do an ultrasound very early on in the cycle, preferably between the 2nd and the 5th day, you'll see a lot of very small little black spots in the ovary that'll measure between 2 and 10 millimeters on ultrasound. And these are the follicles that are developing or potentially can have an egg in them. And if you do this in somebody with good ovarian reserve, you usually should see 5 to 10 per side. So you don't want to see 40 or 50 because then that's abnormal on having polycystic ovaries. But when you have less than 5 to 10 follicles in the ovary at the early part of the cycle, it implies that you have diminished ovarian reserve. So diminished ovarian reserve means that it's harder. If we gave the same person the same amount of fertility drugs and we stimulated two different people and one had a low ovarian reserve and one had a high ovarian reserve, we would expect more eggs to develop and be available for retrieval if you're doing IVF in the women with normal or high ovarian reserve. Age is a more important factor when it comes to predict genetic health of the embryo. In AMH, in women over 35 who have lower AMH levels will tend to have higher aneuploidy rates. But in women under age 35, the AMH level doesn't correlate with aneuploidy. So it helps us. How does this help us? It helps us guide women's decision making. Having a low AMH doesn't mean that you're not going to get pregnant, not going to have a baby. And having a high AMH doesn't mean that you are. It just means that you fall in the range of normal, or we're concerned that if you're 33 years old and you have a low AMH level of, let's say, 1 or 0.7, that your ovary is acting more like somebody 39 or 40 instead of somebody in their early 30s. And that plays a role both in how we might manage you, how aggressive we might want to be in trying to treat people getting pregnant, whether we want to go more stepwise in trying fertility drugs or being more aggressive and going to more direct treatment like in vitro fertilization earlier on. A lot of couples come in, a lot of single women come in, let's say, concerned about their fertility potential. And fertility cryopreservation is a major concern now, particularly with delayed childbearing. Obviously, some people they haven't met the right person, or they don't feel this is the right time to get pregnant. In couples that are concerned about COVID and don't feel comfortable being pregnant, fertility preservation with freezing embryos or eggs becomes more of an issue. And the question always is, well, what can I do to find out if I'm okay? And if I'm not okay, what should I do about it? And the reality is that we can do these tests that'll give us some idea of where we are in that reproductive cycle. And a good test is always reassuring. If you have a low AMH level or a high FSH or a low antral follicle count, that's going to imply that the ovary has less reserve to it. And from a fertility preservation standpoint, the answer to the question is sooner is better than later. But also with fertility preservation, if you're 33 with a great AMH value and a great antral follicle count, pretty much any woman over 30 who is not trying to conceive now should consider the concept of egg freezing to preserve their fertility down the road. I've recommended this to my daughter for years. She's 28 now and she's finally getting the hang of it. Yes, Dad, at 30 I'll freeze eggs. So, a woman in her early 30s, if you're not planning to get pregnant in the immediate future, consideration for freezing eggs is great. The mistake that we sometimes see is patients come in, they check their AMH level, and they go, okay, I have a normal AMH level, and I feel good, I don't have to worry. But it's kind of like buying car insurance in that you don't want to wait until your ovarian reserve is bad to then try and preserve your fertility, because your ability to produce eggs is going to be less. You're not going to make as many eggs for the same dose of fertility drugs, and those eggs aren't going to be as good a quality. So from a fertility preservation standpoint, age is probably the most single important factor. The ovarian reserve testing markers are helpful in giving you a sense of where you are in that spectrum, but the decision, should I or shouldn't I freeze eggs now, really should be based on age and what your how long do you anticipate before you're going to get pregnant. So the basic part of a fertility evaluation on the male side is simple. It includes just looking at sperm predominantly. On the female side, there are three basic questions. One is, do you ovulate normally? That's not going to be discovered by doing ovarian reserve testing. For that, you either need to do a progesterone level by blood, look at a basal body temperature chart to see an elevation in temperature in the second half of the cycle, or have an ovulation test kit that shows a signal that ovulation is going to occur with menstruation happening about 2 weeks later. All three of those things will tell you ovulate. The anatomic assessment of the uterus and tubes is done with a hysterosalpingogram that tells us the uterus is okay, the cavity is fine, and that the tubes are patent, and anatomically there's a low likelihood of any hidden disease. And the third component that is a key question is, what's my ovarian reserve? Is your overreacting age appropriate? And then how do we go about treating it? From a practical side, there's no specific treatment of poor ovarian reserve. There are some vitamin supplements that can be used, such as DHEA, CoQ10, vitamin E, omega-3s. All of these may be beneficial in improving ovarian sensitivity. Is it going to take somebody who has a very, very low AMH level and turn it into a normal one? Probably not. But it may help in general, the quality of the eggs that we do get when we stimulate somebody. So there's no magic drug we can give to fix an AMH level or diminished ovarian reserve. The treatment is really treating somebody and treating them to get pregnant or preserve fertility. And the treatments to help people with diminished ovarian reserve get pregnant more quickly fall into two basic categories. The first is to use ovulation induction, usually coupled with intrauterine insemination. And this is done by using either oral or injectable medications. Most commonly, we'll start with oral medications such as Clomid or Letrozole, or otherwise known as Femara. And beginning the third day of the cycle for 5 days, we use these ovulatory drugs to kind of fine-tune and produce the best egg that we can. Sometimes you'll get 2 eggs. Really, you're going to get 3, 4, or 5 eggs developing from oral medications alone. You can use a combination of oral fertility drugs, ovulatory drugs, combined with low doses of injectable medication. And that seems to work sometimes better in patients that have diminished reserve who are older and trying to get 2 or 3 eggs to ovulate. And we can improve the chance of pregnancy by doing artificial insemination or intrauterine insemination at the same time that we use the fertility drugs. So we do monitoring with ultrasounds. We have you use home monitoring with ovulation kits, and we do some blood tests. We figure out when ovulation is going to occur. And after a medication called HCG is given to trigger ovulation, we can plan an intrauterine insemination roughly 36 hours later, and the egg will tend to ovulate in that window of 34 to 50 hours, so we know pretty much we can get the sperm there at the right time. The second approach is to do in vitro fertilization. And in vitro fertilization has a couple different steps in it. The first is to use moderate doses of injectable fertility drugs to try and get the ovary to produce more than 1 egg. And in women that are older and in women that have diminished ovarian reserve, lower AMH levels, lower number of antral follicles, we would use higher doses of medication to try and compensate for that. So often women that are 40 years old or women with diminished ovarian reserve will use twice the amount of fertility drugs as somebody 25 or 30 years old with normal ovarian reserve, so that we can get the best number of eggs out of that ovary. And with IVF, women will use fertility drugs for 10 to 12 days. They're monitored by ultrasounds and blood tests during that time to see how their ovaries are responding. We can adjust the medications to get the most ideal response that we can. And then at the time of egg retrieval, usually around day 14 to 16 of the cycle, we can retrieve the eggs, fertilize them with the sperm in the dish, and let the embryos develop. You then have the option of biopsying embryos to make sure that they're genetically competent, that they do not have evidence of aneuploidy, which are an abnormal number of chromosomes, and the best embryos to transfer, the ones most likely to work, with 98% confidence that the biopsy report's going to correlate with what the embryo is, are going to give us the best possible outcome. So, in review, basically, ovarian reserve is something that changes over time. When you're younger, you have better ovarian reserve than you're older. If you've had an insult to the ovary, if you've had surgery to the ovary, if you've had chemotherapy for treatment of a cancer, if you've had any radiation treatment, these things can make the ovary not respond as well, not have as good ovarian reserve. Sometimes women that have been on birth control pills for long periods of time, and I'm talking years, not months, may artificially have a low AMH level, and usually we have to get them off pills and wait 3 or 4 months and see if that will turn around and be normal, or is it reflective of the way the ovary is and have nothing to do with the pills. Being on birth control pills doesn't extend your time to menopause, it doesn't shorten it. Having diminished ovarian reserve doesn't really tell you when you're going to go through menopause. Women with low ovarian reserve at a young age may have menopause a year or 2 earlier than somebody with normal ovarian reserve, but there's no graph that says if your value is 1.3, you're going to go through menopause at 47.5 instead of 52.5. That doesn't exist. So in general, we may expect menopause a year or 2 earlier than the 52-year-old average, but that won't affect us from a fertility standpoint when you're younger. The key is for us to maximize your fertility when you come to us to see us. We can't go backwards. We can only assess your fertility where it is and try and move forward from there. The success rates of treatment depend on what we're treating and what medications we're using to treat it. If you're using ovulatory drugs for the treatment of ovulatory dysfunction in a young person with normal ovarian reserve, you see very good success rates. You'll see 18 to 20% per cycle because we're recreating what's happening. If you're doing ovulatory induction with insemination as a treatment of infertility, for unexplained infertility, pregnancy rates are going to be more in the 8% range per cycle with oral fertility drugs and twice that with injectable medications. And if you're treating unexplained infertility or mild male factor with injectable fertility drugs with insemination, we'll expect pregnancy rates in the 18% range per cycle. The real benefit is considering IVF for situations of unexplained infertility that have not conceived easily with an ovulatory drug and insemination. And with IVF, the success rates, if we put a normal embryo into a normal uterus, and by a normal embryo I mean one that's genetically been tested and found to be euploid, it has a appropriate complement of chromosomes present that can implant. In that subgroup, we're going to see 50-60% pregnancy rates with the transfer of one embryo. So the answer to success rate, it depends on who we're treating. If we have somebody who has very diminished ovarian reserve, the problem is the number of eggs that we have with IVF is going to be less. The number of embryos that result will be less, and particularly in women that are older, there's a much higher incidence of abnormal embryos that just aren't going to work. So the success rate is going to be lower in that subgroup of patients. Uh, we recommend birth control for long term. Birth control should be individually based on what your needs are at the time. There's no problem with long-term use of contraceptives or contraceptive implants or non-contraceptive uses of non-hormonal-based contraceptives for prevention of pregnancy. If someone's been on a pill for 10 years, it's probably a good idea to get a breather of it coming off of it. But sometimes when you're on a pill a long time, you might not get a period right away when you come off of it. We may see an artificially low AMH level, but usually within 3 months it'll come back to whatever it's going to be. Another question: does the number of failed IUIs affect the ovarian reserve for future treatment? The answer to that is no. Ovarian reserve is not going to be affected by using fertility drugs for 1 cycle, 5 cycles, or even a dozen cycles. It's not going to be affected by doing an IVF cycle within reasonable numbers of times. Ovarian reserve is going to be affected by aging because you're older. It's going to be affected by somebody doing surgery and mechanically interfering with the ovary. It's going to be affected by exposure to radiation or chemotherapy for treatment of cancers. But fertility treatment in itself, whatever we do now, is going to have no adverse effect on how your ovarian ages in the next couple of years. What long-term effects can Lupron injections have? Well, there's 2 kinds of use of Lupron. One is using Lupron for the short term, which we use very commonly in a frozen embryo transfer cycle, where somebody might be on subcutaneous Lupron for 4 weeks, which is very short acting. It's out of your system within a day or 2 and is going to have no long-term effects whatsoever. The other Lupron is a depot Lupron, which can be given as a monthly or every 3-month injection. And that's used mostly for treatment of endometriosis in the female. And if you're using Lupron long term, once you stop it, your body's going to go back to what it is. It's not going to change the ovaries, the eggs that are there. If you shut the ovary down, it doesn't stop and then come back when you start it back up again. It continues to age, whether you're ovulating or not, or whether you're on hormonal suppression or not, with pills or Lupron or anything else. If you're using depot Lupron for extended periods of time, you're probably not on it long enough to have any drastic effect, because you shouldn't be on it for more than 6 months anyway. And if you are for more than that, you need estrogen and progesterone feedback. If you're on it for many, many years, then theoretically it would be just like a birth control pill. It could artificially suppress the antral follicle count and the AMH level more so. But when you come off of it, you should revert to what is normal for you. A couple of other questions. Who are the list of doctors that are on staff? There are 3 of us in our practice. It's myself, Dr. Ackerman, and Dr. Chung. All of us are equally competent in treating you and providing the whole range of fertility services, whether it's just assessing where you are, fertility preservation, use of third-party reproduction, or and so forth. If speaking Spanish is very important, Dr. Ackerman's your man. If you prefer a female doctor to a male doctor, Dr. Chung Fair is terrific. But we all provide medically, excellent patient care. We focus on customer service as well as providing evidence-based medicine and the best possible outcome we can give you. Question was, what's an example of diminished ovarian reserve? An example would be if we had 2 patients and one had good ovarian reserve and one didn't, and we treated them for an in vitro fertilization cycle. If we gave them both the same amount of medication, in the patient with good ovarian reserve, we might expect 15 eggs to develop, basically. And if we gave even with a higher dose of medication in somebody with diminished ovarian reserve, we may only expect 5 or 6 eggs to develop. And in sometimes if you're stimulating somebody who's 43 with very low ovarian reserve, you may only get 2 or 3 eggs. So the real difference is when we stimulate someone with fertility drugs, we just get less eggs. If that egg that we get results in an embryo that's genetically normal and competent, then it doesn't matter what your ovarian reserve was before we started. The equalizer is a normal euploid embryo. And it doesn't matter if you're 30 years old with good ovarian reserve or 42 years old with crappy ovarian reserve or diminished ovarian reserve. If we have normal embryos to work with, those embryos pretty much have equal competence in working. Question came up of what about if I have a tube blocked? Remember, you have 2 tubes and 2 ovaries. Naturally, over a period of a year, you'll have half the ovulations occur on one side and half on the other. It usually goes back and forth, but sometimes you can have 2 back-to-back months on one side and then on the other. So having 1 tube blocked doesn't mean that you can't get pregnant. It just means how likely it is in a cycle will be half as high because only one side's going to be working. Now, if that tube that's blocked is also blocked at the end and it's dilated, so it looks like a little sausage or a big water balloon, stretched out hot dog kind of water balloon, then it gets more complicated because in the presence of what's called a hydrosalpinx, the fluid in that tube can actually leak back into the uterus and make it harder for an embryo to stick. So if you have a blocked tube, the treatment options we've got are to use a fertility drug to try and get both ovaries to ovulate, so you're more likely to ovulate on the good side. You can consider surgery to fix the tube, or in some cases you have to remove the tube, as well as ensure that there's no evidence of disease on the other side that's hidden that we can't see. But if you have a tube that's blocked and you haven't gotten pregnant quickly and you don't need surgery to remove the tube, IVF again becomes a very good option because you're able to get eggs from both ovaries, fertilize them in the dish, and put the embryos back into the uterus. Question of does ovarian reserve change every month? It's not going to change drastically. The number of antral follicles you'll see in 1 month compared to the next may vary by 1 or 2 just based on who's measuring the antral follicles. And the AMH level may vary a little bit. If it's in the same lab, you should see a similar pattern in results. 10 to 15% variation from 1 month to next is normal variation of any assay, but you're not going to go from an AMH level of 0.7 to an AMH level of 2.5 in 1 or 2 months, no matter what you do, and it's not going to go from 2 the other way as well. There tend to be a trend or a pattern. People who run normal values, 1 month might run a 1.5, and next month a 1.8 or a 2.3. It would be rare for them to run something under 0.5 or all of a sudden had a value of 5. Question of I'm 42 and is it worth evaluating ovarian reserve or ovum donation? I think at 42 you need to look at ovarian reserve certainly from the standpoint of both AMH, FSH, estradiol, and antral follicle count. Combine that with your history in general and talk with your treating physician as to what my chances of success might be if I pursue one direction versus another. If you just look at age related to IVF treatment, there's no question that if you use an egg donor who's under age 30, you're going to have a much higher success rate per cycle that you stimulate somebody compared to trying to stimulate somebody who's 42 years old. There are some 42-year-old patients that have very good ovarian reserve that'll make lots of follicles, but you still have to realize that the aneuploidy rate goes up with age. So whereas if you have somebody who's 30, 70% of the embryos that you biopsy that you think look terrific under the microscope are going to be normal. If you look at somebody who's 40, only 30% of them are going to be normal. And if you look at women who are over 42, about 80% of embryos are going to be aneuploidies. So if you have good ovarian reserve and you're able to produce, 5 or 6 or more eggs, and we get 3 or 4 embryos, and we may get lucky and get a good normal embryo. But if you have very low ovarian reserve and you're 42, then it's less likely for that to occur. And then it's a matter of, okay, do I want to try with my own eggs first, as most women feel a need to do, or do I just jump to a donor? Certainly women, once you get to 44 and above, donor egg is almost always the best option, but it's a matter of persistence, finance, and how much you're willing to be able to accept, as far as, I know it's a long shot, but I'm okay trying, or this is very frustrating, I just want to get on with having a family. And we're here to help you have a family. We're here to counsel you on what your chances of success are with the different options that are available. Question here is, I did 6 IVF 6 months apart, and the first cycle has 16 eggs and the next only 6. Depends on age. There's some variation cycle to cycle. Some people will respond better to one protocol or another. In general, patients tend to follow a pattern, basically, in the way they stimulate once, they stimulate again. But ovaries are all different, and sometimes you do better than in other cycles. You have to have those cycles looked at and ask that question to someone who can see the data and see what was done differently, if anything, or is it just natural variation. Next question is, what if a fibroid is blocking the cervix? Obviously, if the fibroid's blocking the cervix, if the blood can come out, sperm can go in. The problem more is if we need to do IVF and you have an anatomic issue that's perhaps making it more difficult for the cervix to get a catheter through, then that may be more of an issue for us there. Next question was, how successful is IUI if there's low motility in a woman with polycystic ovaries? Great question. If we break that down into 2 different parts, the first part is, in someone with polycystic ovarian syndrome, they're not ovulating. So once you achieve ovulation, you're going to achieve a natural pregnancy rate in somebody of that age who ovulates. So if we just break it down into women under 40, in general, pregnancy rates are going to be in the 18% range per cycle, who are just saying, okay, let's throw away the condoms and let's try and have a baby. You'd expect each month about 18% to get pregnant. In a cycle where ovulation occurs, it will be the same 18%. Now, if you have a compounding issue such as a low sperm count, then how low that sperm count is will reflect how difficult it will be to get pregnant. If you've got normal sperm count is 15 million sperm per cc with 40% motility. If we have sperm that are half normal, then our success rates are going to go down significantly. And the lower the sperm counts and the lower the sperm motility, the less normal sperm that are present for us to use to inseminate with, and success rates are going to be very low. So when we have sperm counts that are in the 10 to 15 million range, or motilities in the 20% or above, we'll do fairly decently. But once you get below 5 million sperm per cc of fluid, and you get motilities that are certainly less than 20%, then it's going to be much more complicated, and the success rate's going to be very low, and one really should consider moving to IVF more aggressively. With IVF, you can bypass any issue of sperm motility as long as they're live sperm and morphology by injecting an individual sperm into an individual egg with intracytoplasmic sperm injection. Okay, question. I was 40 years old. I had my first son 8 years ago. I've had 4 rounds with you guys. 2 with my first son, who was born in '98. And my last son was born in 2001. We're fantastic, and I'm 51. It can be done. Thank you so much, and we appreciate your trust in us and support of our program. And we are happy to share with you the love and joy that has brought you. So thank you so much for sharing that with us. Question of, if you have polycystic ovarian syndrome and don't get monthly periods, how can blood work that is dependent on particular days of cycle be done? AMH level can be done at any time. With PCOS, the FSH estradiol levels mean a little bit less. More than likely, you'll have an inverted ratio, meaning the LH will be lower than the FSH. But the answer is they're done randomly. Because if you only get a period every 90 days and you're not ovulating, in essence, every part of the cycle is like the beginning of a cycle because you're just not ovulating. So we just do the test randomly any time in the cycle, and that suffices to give us a pretty good idea of where we are. Again, usually the AMH level will be a little higher in patients with PCOS. Quite a very good question. How many times should I consider IUI before considering IVF? It depends, again, why we're doing the IUI, but in general, we would say 3. The exception to that being if the sperm is really, really poor, then doing IUI is maybe working to do something a little less aggressively, but it's not going to have a very high chance of working. Patients with diminished ovarian reserve, patients who are older, patients with severe male factor may be doing themselves a favor by being more aggressive and going to IVF quicker, because we can bypass issues of fertilization and maximize getting good quality embryos while you still have good ovarian reserve. We're going to get better rates in a shorter period of time, which is going to preserve your fertility in the long run. So does Clomid affect your blood work? It's probably best to do these tests not when you're in the middle of a treatment cycle. Clomid's going to affect FSH and estrogen levels in the cycle that you're taking it. We would recommend doing all your ovarian reserve tests in a cycle when you're not on the fertility drugs themselves. And that pretty much summarizes what it is that we're doing. If you have questions, please come on in and speak with us. If you're confused and your doctor's not explaining things, come on in and let us help explain things to you. Seeing any of the 3 of us in the office is totally fine, and we appreciate you tuning in to our Instagram topic of the day, and would look forward to treating you in our center if you're not already our patients. If you are our patients and you have questions, please address them to us so that we can make sure that we've got your concerns and questions answered at the same time. One last question, which is a good one. What's considered old in fertility years as an advanced maternal age? Chronological age, in general, once you get past 35, things start significantly declining. It declines quicker when you're 37, even more so when you're over 40. After 42, That's pushing the envelope. We've been successful with women with their own eggs up to 46, but most women in their, let's say, who are in the 42 to 46-year-old range, most of those women are much more successful with the use of donor eggs than their own eggs. So our time is up for today, but I welcome you to come on in, bring your questions, tune into our next Instagram topic of the day, and we'll be more than happy to answer them. And certainly we're more than happy to help treat you and share in the joy of making your dreams and come true and helping you have a family. So have a good day, stay safe during these trying times, and come on in and we're here to help you. Have a good day and take care.